Hello, I'm Jennifer Chase. I'm the Associate Provost of the Berkeley Division of Computing, Data Science, and Society, and the Dean of the School of Information. On behalf of the division and of the Berkeley Institute for Data Science at UC Berkeley, of course, we welcome you to this conversation on COVID-19. This is the second in a series of seminars in which we look at how Berkeley researchers are using computing and data science to inform pandemic response and recovery. The focus of today's conversation is how can we understand and seek equity as we face COVID-19. Emerging data show that the pandemic is amplifying socioeconomic disparities and inequities. Here, we'll look at how choices about data sources, research methods, and technologies, and also how our approaches to building relationships with marginalized communities shape our understanding of and approach to addressing these problems. We'll hear from three fantastic researchers. First, Ziad Obermeyer from the School of Public Health. Second, Neela Forrestal from the School of Information and the Department of Electrical Engineering and Computer Science. And third, Sarah Vaughn from the Department of Anthropology. So we are going to get started first with Ziad.
Thank you so much, Jennifer. So I'm on faculty at the School of Public Health. I actually trained as a doctor, but most of my work these days is building algorithms. And the goal of that work is basically to help people working in health make tough decisions. So that's doctors working in the clinic, it's policymakers who are allocating resources. And I'm actually very optimistic about that work and about the role that algorithms are going to play in health. But that's one reason that I also spend a lot of time worrying about what can go wrong when we apply algorithms to health. So I want to start by telling you a story. And that story is about an algorithm that was made by people with really good intentions who were trying to do something really important. But that algorithm ended up hurting a lot of people, most of them Black and poor. So we're going to post in the live chat a link to the paper if you want to read more. I'll summarize it, but I'll also try to summarize the lessons that I took from writing that paper about how bias gets into data and then into algorithms. And that actually really helped me to make sense of COVID, about where data and algorithms could help and where that might go very wrong. So that's where I'll end up. But first, I'll tell you the story. And that story starts 10 years ago. When health systems first started to realize that they couldn't just keep doing things the old way. So the old way was sitting around, waiting for people to get sick, and then treating them when they walked into the hospital. And that game, which is, you can think about as basically waiting around for people to have heart attacks and other health events, is not good for patients. And it's also very expensive for our healthcare system. So all these hospitals started to see the writing on the wall and realized that that old way had to go. So the new way was to get much more proactive, to get ahead of illness, catch it before it happened. And to do so, they started rolling out a bunch of programs to get help early to the patients who needed it the most. So that's like a dedicated phone line that patients could call whenever they needed help, a team of nurses, extra primary care appointments, home visits, medication refills, whatever people need. And that works. So patients love it. The outcomes got better. The costs got lower. But there's a catch. All of that extra help itself costs money. So we can't do it for everyone. And that's where algorithms come in. So algorithms are doing the job of finding the people who today look like they're going to be okay, but tomorrow are going to get really sick. And then we can zoom in on those people and give them all the extra help that they need. So that approach, that algorithmic approach to targeting, was very popular. And almost every healthcare system in the country is using algorithms to do exactly this job. And so as one statistic, the algorithm that we studied in this paper That one alone was being used to screen about 70 million people a year. And the family of algorithms like it is about 150 to 200 million people every year. So that's like most of the US population every year. And I think it's important to call out, this is a good thing. This is exactly the kind of thing we want the healthcare system to be doing, to be looking ahead, not waiting around for illness to happen, predicting things that humans can't, and helping those who need it the most. So I hope that sounds good to you too, because I think that's the vision. But there was one problem with this vision. So I told you that the algorithm was supposed to be finding people whose health is going to get worse. And when I said that, you probably know what I mean, but an algorithm does not. An algorithm needs to be told about a specific variable in a specific data set. And so a really important question to ask is, what is that variable? And how did the people who made the algorithm translate this messy concept of health and deterioration into a very specific variable? Now, I can't see you because we're on Zoom, but I've taught enough classes to know that this is about the time of the lecture when people start getting a little bored. This feels like kind of a technicality. It's like a little tedious. I understand. I get it. But here's why it's not. So it turns out that in all of the health data sets that we use, there's no variable called health. There is a variable called healthcare costs. And when they trained the algorithm, that's what they used. The algorithm was finding people who were okay today, but who were going to generate a lot of costs next year as a proxy for who is going to need healthcare over that next year. But there is a world of difference between needing healthcare and getting healthcare. And that's especially true if you're Black in America. So take two people with the same number of chronic illnesses, the same illness severity, however you want to measure illness. One patient's Black, the other's white. That Black patient is on average going to cost far less. In our data set, it was about $1,000 a year. And part of that is because she's poorer and she has less access to the healthcare system. Part of that is because our healthcare system treats her differently because of the color of her skin. Now think about what that difference means for the algorithm. We thought we told the algorithm to find people who are going to get sick. What we actually told the algorithm was to find people who are going to cost a lot of money. So you can imagine what that looks like to the algorithm. So everyone is waiting in line to get into these programs. So just picture them. They're ranked, they're lined up in order of how much they're going to cost next year. And patients, the handful at the front of that line, they're going to get the extra help, and everyone else is not. Now, they're ranked from most to least expensive, not from sickest to healthiest. And that means that a bunch of healthier patients who happen to be more likely to be white get to cut in line ahead of sicker patients who happen to be Black. So a 60-year-old tennis player who's waiting for his knee replacement is going to cut in line ahead of someone who has to skip doses of his insulin. When we use cost as a proxy for health, we're confusing healthcare costs with healthcare needs. And that disproportionately hurts Black people. And this was not subtle. When we estimated what an unbiased algorithm would look like, it would have more than doubled the fraction of Black patients at the front of the line getting extra help. So when you scale that up by tens of millions of patients per year, that's a lot of pain caused by choosing the wrong variable to predict. So there are a couple of lessons here that I think are relevant to how at least I thought about COVID. The first lesson is to be careful what you ask an algorithm to do. It's going to do it. If you ask it to predict healthcare costs, that's what it'll do. It won't pause to ask if cost is biased because of historical disparities. It won't point out that Blacks are underrepresented in the highest risk groups. That's on you. The second lesson is, I guess, technically about algorithms, but you can also find this lesson in a lot of self-help books. Most of the things we really care about in health, in society, in life, we don't measure. Instead, we have proxy measures. And proxy measures can be very dangerous. How do I measure how my career is going? Is it my salary, my citation count? Is my fulfillment in life about how many Instagram followers I have? Hopefully not, because I think I literally only have one. But all that is to say that algorithms are not the only ones that can be distorted by bad proxies. So here's what that might mean for COVID. There's a lot of interest in getting ahead of the epidemic, predicting which geographies, which communities are going to be hardest hit. And that's good. We do need to target our resources to where they matter the most. But what exactly are we predicting? Usually it's the number of COVID cases or deaths. But COVID case means testing positive for COVID. And testing means access to healthcare. And if you never get tested, we'll never know that you had COVID. We often think that we're predicting a biological variable. COVID, it's a virus, we measure it with PCR, it sounds like science. But what we're actually predicting is a proxy measure that's just as much a social variable as a biological one. And that's why that can be so misleading, especially when you forget that it's a proxy. Here's another one. We dread rationing healthcare, and yet there might be a shortage of ventilators. So who gets the ventilator? We often hear that sicker patients do worse. So the received wisdom is give the ventilator to the healthier patient. But that optimizes the wrong quantity. We want to give ventilators to where they do the most good, not to patients who do the best. Healthy patients do better with the ventilator. They'll also do better without the ventilator. So the key quantity isn't the outcome, it's the difference in outcome between the treated state of the world with the ventilator and the untreated state of the world without it. Giving the ventilator to healthier patients is just going to punish sick patients who are disproportionately poor, Black, and disadvantaged, even though it might do them the most good. So I'll wrap up by just saying that all of these pitfalls are not unexpected here. This is a new field. We're all just figuring this out, and none of this has been really mapped out. But they can be mapped out, and these pitfalls can be fixed. And that's where the story I told you ends. When we first saw the extent of bias in that algorithm I told you about, we reached out to the company that made the algorithm, and we told them. And they were incredibly responsive. They worked with us to retrain their algorithm, same data set, same everything else, just predicting health instead of just cost. And together, we made a revised version of the algorithm that was over 80% less biased than the original. We'll post an article that describes that work as well on the live chat. But we took advantage of this to turn this into a larger pro bono consulting project where we're working with health systems, with insurers, with state and federal regulators to understand and remove bias from health algorithms. And I think all that just illustrates both the danger and the promise in this area. On the one hand, these small technical choices can dramatically scale up existing bias in our data and harm lots and lots of people. On the other hand, correcting these small technical choices can overnight make a huge difference.
Thank you so much, Ziad. That was really, really fascinating. Let me ask you a couple of questions. You were quoted in the LA Times at about the time that article came out. And the quote of yours was, we shouldn't be blaming the algorithm. You said we should be blaming ourselves because the algorithm is just learning from the data we give it. And you've also just said from the proxies we give it. Does this statement hold for any of the COVID-19 predictive models that you've seen and the algorithms of which you're aware?
Yeah, I think, some of the factors that I mentioned definitely raise some red flags for me. So often we're predicting confirmed cases. We are putting a lot of stock in that as our barometer of how the epidemic is going. And we know at the same time that a lot of people just lack access to healthcare. That's going to mean that precisely those communities that are likely to suffer the most from COVID are the least likely to be tested. And so I think that, any time that we're measuring or predicting one of these variables that's like a hybrid of a social construct, like access to healthcare, with a biological one, do you have this virus in your bloodstream? Those kinds of errors are going to happen. I will say that, this is what makes the work of a lot of people, including some of my colleagues in public health, so important to do population-based surveys. So I think that getting a actively collected set of data about the prevalence of COVID in different places and different communities is really, really important. And it is a really vital complement to the data that we're getting from the healthcare system that builds in all of these biases.
So a second version of this question, actually, as I started to hear about the huge disparities in mortality, I mean, just so different from, the population. And this is presumably being caused by comorbidities, by other conditions which people have. Those conditions may in fact be exacerbated by the kinds of effects that you measured. How do you think your insights might help to prevent these socioeconomic disparities, which become even more manifest in a health crisis like COVID-19?
Yeah, I think that, when we see these statistics of, in Black communities, the mortality rate is twice as high. I think, I find those statistics so hard to interpret because on the one hand, I think it's pretty obvious that Black communities are going to suffer more because of all the factors you mentioned, because chronic illness is so much more widespread, because access to healthcare is less, because there are fewer ventilators serving those communities effectively. On the other hand, that 2x number could be much, much worse because we're only measuring, the tip of the iceberg of the actual COVID cases. And, we don't have the data infrastructure that lets us track what's actually happening. So in a lot of places, for example, you can see that there are, since the COVID epidemic started, there are these spikes in mortality, of course, that are in confirmed COVID cases. But there are also these huge, and in many cases, even bigger spikes in mortality in other people who are not confirmed COVID cases. And so that could be undiagnosed COVID. It could be that surgeries and other essential procedures are being canceled so that health systems can prepare for an influx of COVID. And so I think that, those numbers are just incredibly hard to interpret, but all of the signs are pointing us to, evidence that these communities are hit much harder. So I think that when we can use those numbers to target resources, that's very useful. I think that, it does bring up some other questions. And I think a lot of the discussions we've had, as I mentioned, are about rationing healthcare. And so who gets extra care when care is limited? And I think that the current heuristics that we're using, where healthier people should get care ahead of sick people, actually risk reinforcing all of these disparities, even when those sick people actually need the care more and would benefit from it more. It would be socially more efficient to deploy that care to sicker people.
Thank you so much, Ziad. This has been fascinating.
Thank you.
We now turn to Neela Forrestal, and I think you have a presentation for us as well, yes?
Yes, thank you, Jennifer, so much, and thank you, Ziad. That was fascinating. So hello, I wanted to start today by just acknowledging my privilege to be able to be here and to speak at this very difficult time of a deadly pandemic, and also to use it as an opportunity for us to think more deeply about who gets to talk about data. Similar to Ziad, I'm going to address 4 points, and I do have some resources to share as well at the end. So I wanted to start by talking about some of my own past work. A lot of my work has been around how marginalized or disadvantaged groups make use of social systems. And as a computer scientist and as a designer, thinking about how technological systems can be designed to better meet human needs. So for instance, some of my work has been looking and studying how Muslim Americans gather and share information online related to elections. So I found that activists, journalists, civil rights groups use social media to craft counter narratives to the dominant narratives that exist that target and demonize them. In other work, my group has studied how young women have reconfigured the Instagram platform to create more intimate social spaces online. So these are spaces that they call Finstas, which is fake plus Instagram. And they are private accounts that people only share with their close friends. They are spaces of mutual support and they push back on societal expectations of perfection for young women, and they even poke fun at those expectations with #UglySelfies. And finally, I've worked on how online social systems can be designed to support collective action and mutual aid. And this is work that seems particularly timely at the moment. I did this work with Amazon Mechanical Turk workers, who are people who are dispersed around the world, and they complete short tasks online. So this is work that looks like content moderation work or data labeling work. And unfortunately, the people who do this very important work receive very low wages and work under very difficult conditions. So I've done work together with Turkers, as they call themselves. I did over a year of ethnographic field work and a process of co-design with these people to create a system that we call Dynamo. And this was a system that was specifically designed for people to raise ideas about collective action, issues that they share together, discuss, agree on them, and take action. So as one example, Turkers used our platform to co-write a set of ethical guidelines for researchers who use Mechanical Turk. They published those guidelines online, and it's been currently used by a number of researchers and IRBs, which are our university's research ethics review boards for research that uses Mechanical Turk. So that was some of my previous work, and I wanted to use that to talk more about how my group has accounted for health and socioeconomic disparities in this research. So I want to talk about a couple different questions. One question is, where do we look for data? And sometimes the question is even, what data do we omit and not look at on purpose? And working with marginalized or at-risk people requires a lot of care, as Ziad talks about, in choosing what those research methods and data sources are. For instance, in our work on Finstas, the fake Instagrams, we purposefully didn't ask for access to the actual content of the Finstas, the actual pictures that people posted. And the main reason for doing this was that Finsta photos might include compromising photos of minors. So even though it would have been great for the research, we instead opted to interview Finsta users. So for some of our other work, including our research with Muslim Americans, we did a lot of work to build relationships and trust with community leaders before we even started to gather data. And this is to ensure that the research serves their interest and that they are partners in the work, not just research subjects. And finally, and particularly relevant to COVID-19, is thinking about how we work with people who are of lower socioeconomic status, and making sure that our research doesn't actually add as a burden to what they're already dealing with. And I had some experience doing that with my work with Amazon Mechanical Turk workers, where I was working with people for whom time that they were sitting at a computer was time that they needed to be making money to pay their bills. So I factored that into my research approach. I tried to go where they were. I spent a lot of mornings waking up, logging into Turker chat rooms, announcing that I was there, and then sitting there and reading their discussions and jumping in if something relevant to my research happened and asking questions. And second, it factored into how we actually designed the system, Dynamo. So we made it such that people could use the system in really short bursts of time that they had between the tasks that they were already completing. So in a way, we made the barrier to entry and action low for that reason. So that was some of the ways that I've accounted for different kinds of disparities in my own research approach. And I wanted to end by talking about how we can best leverage computing and data science in this kind of research. So computing and data science, I think, can help in two ways. They can help us identify the problem, and they can help us identify and design a solution. And as Ziad mentioned, unfortunately, but predictably, COVID-19 has had drastically harsher impacts on marginalized and low-income communities. And my past work and being in the School of Information has led us to study how marginalized groups are accessing information about COVID-19. And the impact that potentially wrong information or misinformation has on them, and how those effects can be mitigated. So we're looking at COVID-19 misinformation. We're particularly looking as it circulates in private groups like family chat groups, where trust is very high, and we also have very limited means of accessing the data. So these are often private encrypted groups, similar somewhat to Finsta's, and we have to get very creative in how we gather the data. Some approaches that we're considering is, for instance, a bot that people could voluntarily add to their messaging groups that automatically detects and shares information if it detects misinformation, although we have to be very sensitive in how that is designed and how it actually does that. And data can also be used to identify solutions. So some of our preliminary work around misinformation suggests that interventions by community leaders can be effective at countering misinformation. So we can test that hypothesis by analyzing past data to measure the effects that these different kinds of interventions have. I wanted to wrap up by sharing some resources that we're using and building on in our own research that I think could be useful for other people working on these problems as well. So I'm just gonna share my screen. So the first resource is the Feminist Data Manifest No. This was created by the Feminist Data Workshop, and I was a member of that. We co-authored the set of basically refusals and commitments that refuse harmful data regime and instead, and at the same time, commit us to new data futures. I've pulled out three sections from the Manifest No that I thought were particularly relevant to COVID-19 technologies. I'm just going to read over them, but there's a lot more in the actual Manifest No that I suggest you look at if you're interested. So the first one is we refuse the assumption that risk and harm associated with data practices can be bounded to mean the same thing for everyone, everywhere, at every time. And instead, we commit to acknowledging how historical and systemic patterns of violence and exploitation produce differential vulnerabilities. Second, we refuse the use of data about people in perpetuity. We commit to embracing agency and working with intentionality, preparing bodies of data to be laid to rest when they are not used in service of the people about whom they were created. And third, we refuse work about minoritized people. We commit to mobilizing data so that we are working with and for minoritized people in ways that are consensual, reciprocal, and that understand data as always co-constituted. The second resource is an amazing playbook. It's the Digital Defense Playbook made by Our Data Bodies, which is an organization that works with Black communities around the country. A lot of their work has been around surveillance and community safety. I suggest this for anyone thinking about surveillance, privacy around COVID-19. These people have a lot of experience actually working with that in practice. And the third resource is from the Bay Area Transformative Justice Collective. It's the PODS and POD mapping worksheet. So transformative justice is a view of justice that pushes us to think beyond just a single instance of harm or single instances of harm, to think about the underlying societal and social conditions that enable harm and how communities might be transformed to change those underlying conditions. PODS and POD mapping is a specific practice that they do in these transformative justice collectives to think about who are the people who you trust and can rely on. And even though this was developed in the context of child sexual abuse, there's been a lot of talk about how practices such as POD mapping can actually be used for COVID-19 mutual aid. So these are three resources that I think are very useful for my own thinking, and I think for other people who are thinking about technology in the context of COVID-19, and particularly how it impacts people differently.
Great. Thank you so much, Neela Forrestal. This has been fascinating. I have a couple of questions for you. First, what are some of the dominant narratives about COVID-19 of which you've become aware that we need to counter, especially those about marginalized populations?
So I think one that is very dangerous is that Black and Hispanic people are dying at record numbers because of their own risky behavior. And there's a long history actually of attributing systemic or societal issues, what Ruha Benjamin actually calls pre-existing social conditions, to the individual person's shortcomings or even to their moral character. And as researchers, as a researcher myself, and wanting to strive to actually do good work, do work that is in the service of equity, I think that we have to be very self-aware about the role that research has actually played in creating those narratives. Research on Black people specifically conducted by researchers who were not members of those communities or engaged with them in a meaningful way, has frequently mischaracterized, for instance, tightly knit Black communities as cliques or gangs, or has misunderstood actions that people are taking for their survival as, you know, risky behavior. So that's something to be very careful about, I think.
Great. And so I'm wondering, whether both in your research and for other people doing research, what are some of the data and methods of analysis that you think can be employed to help counter these narratives?
That's a really good question. I want to refer back to another dominant narrative that I think is very harmful at this time. And I think that's a false dichotomy that we have between where we're stuck between surveillance or freedom, security or liberty, national security or human rights. And we're stuck as if we have to choose one of these and we can only have one. And feminism actually teaches us to question and rethink these binaries, and do they actually exist? And this is one of the places where I think we have a lot to learn from people who have been dealing with surveillance much more harshly and for a much longer time. So I'm going to refer actually back to the digital defense playbook that I briefly mentioned. One of the things that I've learned from that is this mental shift that we need in thinking about what our communities need is security, to thinking about what we actually need, which is safety. And the playbook does a really good job of explaining why these two are different. So security is what we do to things. We secure our possessions, we secure our communications. And usually when we're thinking about security, we're not really centering human factors. So an alarm system doesn't by itself ensure that we are actually protected from actual harm. Or for instance, a police body camera doesn't by itself prevent police brutality. So even though it might secure things, it doesn't necessarily mean that we are more safe because of them. So thinking about and centering safety instead makes us ask what actually makes us safe. And thinking about that in the context of COVID-19, tracking and contact tracing, the things that actually make us safe are having knowledge, having reliable information, having relationships of trust with other people online and offline. So these are some of the places where I think we have a lot to learn from marginalized people. These are very hard times, and marginalized people have been dealing with difficult conditions for most of their lives. So people of color have been very well and resourced in maintaining tightly knit communities of mutual aid. People of color have been dealing with and pushing back against surveillance, and while at the same time having to learn how to make their communities safe. And LGBTQ people and disabled people basically invented what building online community is. And so that is something that we need more and more today. So thinking about and centering safety rather than security not only moves us beyond this false dichotomy and getting stuck between having to choose whether we want our health or our privacy, but it also helps us open up our imaginations for what is possible and what kind of futures we actually want to build. And I think that learning from these lessons actually totally shifts our model and how we ask questions and what technologies we actually end up designing.
Wonderful, thank you. Your perspective and Ziad's perspective as data science and public health researchers, I think really adds to this conversation. Finally now, I want to turn to Sarah Vaughn, who will give us yet another perspective, which is that of anthropology and qualitative data for COVID-19. So Sarah, please tell us about your work.
Sure, thank you. Thank you, Ziad and Neela for those are fascinating presentations, and especially this last point that Neela brought up about this idea that one should refuse or try to think more critically about the ways in which at-risk communities understand their historical and social relationships to data is quite important, and one way in which I want to sort of come into this broader conversation about COVID-19, at least in relationship to broader issues, particularly around my research on climate adaptation. So I'm an anthropologist here in the Department of Anthropology at Berkeley. And most of my research has been on issues related to thinking about civil engineering and the adaptation of critical infrastructures, specifically dams, sea defenses, and other waterworks in the Caribbean. And so part of those issues when thinking about climate adaptation is to take seriously that those experts and other communities living next to these critical infrastructures recognize that those systems need to be improved, repaired in many cases, but at the same time that disaster itself will still be a potential future which they'll have to live with. So this idea that we live in a kind of context where we recognize that disasters are a potential reality, even as we care for the very environments, infrastructures that we live with, is part of the issue raised around questions of climate adaptation. And so part of why I think climate adaptation is such an interesting case by which to think about a comparative way to get into questions of COVID-19 is precisely because of this issue around living with uncertainty and the ways in which one can even move past, as we've already discussed, questions of security to questions of vigilance. And so what's really interesting about doing ethnographic research on such issues is that ethnography as a method allows one to think in broad sort of comparative cases across historical and cultural contexts. And so working in the Caribbean, which for many people, at least from a Euro-American perspective, is one of, beaches, sun, tourism, vacation, is also a site that, not surprisingly, because of many islands and coastal nations' geographies, are kind of at a pivotal point and kind of canary in the coal mine for thinking about how climate change affects everyday life. And so specifically, my research has looked at Guyana and their historical relationship to engineering sciences, as well as how people, ordinary citizens themselves, live with the adaptation projects happening on the ground vis-a-vis the work of NGOs, state engineers, as well as international consultants working to rehabilitate a dam system that has caused tremendous flooding in recent years in Guyana. And so one of the issues that has come out of rehabilitating this dam system are broader questions about healthcare, and specifically how it is that engineers themselves think through managing and adapting the system to more frequent rain events and sea level rise, as people also on the ground try to understand their newfound vulnerability to waterborne and other kinds of bacterial infections. And so while I did my research in Guyana, a lot of my work wasn't just with these engineers doing their modeling practices as well as dam designing, but also with local humanitarian organizations, specifically the Guyana Red Cross, which would go into local communities and ask people about how they understood the different kinds of improvements that were happening vis-a-vis the dam and canal system, as well as how they lived with the effects of flooding in their everyday lives. And one of those effects was this threat of leptospirosis, which is a bacterial infection that people usually get through contaminated waters from rats as well as livestock. And so the idea for these Red Cross projects was not only to implement vulnerability assessments, which are essentially qualitative descriptions of people's understandings of, say, how high their houses are built, the quality of the roads that they drive and walk on, where and how their livestock are managed, as well as sort of everyday activities of work, as well as healthcare. So they would make an assessment of how to what extent people are vulnerable to flooding vis-a-vis those everyday experiences, as well as to understand the different ways in which people could make their water sources better. And so one of the effects of these vulnerability assessments was then to implement water filtration kits within these different communities where the Red Cross work across Guyana. And so one of the interesting things that came out of these vulnerability assessments and work with the Red Cross was that people were implementing sort of novel ways in which to think about how they could use their basic materials at home in order to build water filtration kits. And so one of the effects of these water filtration kits were people were understanding that on the one hand, even though they recognized they couldn't necessarily rely on the state or even these NGOs to come in to help them when floods would happen, they would have already these built-in networks, social networks, by which they can begin to understand how to build up their own ordinary, quote, I would call them, technologies in order to better manage floods and their healthcare. So part of the effect of these water filtration kits was to better understand from the Red Cross perspective how everyday kind of ordinary technologies could be a way in which people could not only recognize their kinds of vulnerabilities to flooding and health risks, but also how they were creating communities around these very technologies as opposed to or in conversation with those from the state. So there's this broader sort of problem and conversation around how is it one can start to think about a kind of social contract, if you will, through the buildup of ordinary technologies and healthcare that come about from living with climate-related risks and flooding. And so what I find quite interesting about this case of Guyanese climate adaptation, as well as the health risks that come about thinking about climate change, is that really researchers can begin to think about what is technology, not just technology in a kind of cost-benefit assessment, but also technology in terms of how people live with it, how people make it, and the ways in which they understand it forming their relationships to one another, their built environments, different ecologies, different vectors, different state and non-state institutions, as well as their expectations about what the future holds for them. So the important thing I learned from thinking about climate adaptation, and one which I'll circle back to, I think is an issue related to thinking about pandemics and specifically thinking about how healthcare can be understood as a kind of part of a public kind of idea of a social contract, is that climate adaptation is about understanding how past, present, and future technologies are built on and rely on one another. So again, for the specific example of Guyana, their dam system, their different ideas of what it means to build up a water filtration kit is not just based on the specific risks at hand because of intense flooding, but also this very longer kind of historical context and understanding of the different ways in which people expect the state to help them or to not help them. In Guyana's specific context, the understanding of racialized politics between their majority Afro-Guyanese and Indo-Guyanese populations, as well as the different ways in which people understand public and private space. And so one of the issues I think is quite important then when thinking about health-related risk and this idea of what it means to adapt to them from the broader perspective of climate change, as well as local experiences of emergencies and crises, is to take seriously that data comes from somewhere. It's not just this attempt to say, I'm identifying different populations and their risks, but also the ways in which people understand their relationships to the use of technology, as well as its absence in the communities in which they live. And so one of the things I'm really hopeful about when thinking about how researchers respond both quantitatively and qualitatively to emergencies, risks, in whatever form they might be, is that we're recognizing that just that simply collecting demographic data is not enough. And that in fact, trying to understand the broader relationship and not only in terms of how that demographic data is produced, but also related to broader ways in which people use or don't use technologies is quite helpful for understanding how people live with vulnerability in the everyday and become more vigilant to the kinds of disasters that are on the horizon for their futures. And so I think then, especially in relationships to Nilüfer's last point about this idea of trying to recognize how different identities of the different communities by which that we're studying also get shaped by the very technologies that we use to collect data. So there's a kind of, in a jargony sense, a kind of co-production between the kinds of technologies we use in the everyday and the kind of data that we collect and also understand to be important to our research projects. And so trying to draw in a kind of a broader perspective on the ways in which not only people understand how we use different technologies in the everyday, but also the ways in which our very environments, our very institutions, our very political imaginaries, and our expectations about what the state can and cannot do for us shape the way in which we expect technologies to work for us. And I think the most concrete examples that we've had so far in our conversation today, and more generally when thinking about media on COVID-19 has been the question of ventilators, for example, as well as how we think about the distribution of tests or when we don't need to distribute tests, as well as the different ways in which different kinds of media are used to, as Neela pointed out, disseminate information about COVID-19.
Hey, thank you very much, Sarah. That was fascinating. So very often when people think of data, they think of numbers. They think of big data, you know, from social media platforms, from sensors. But sometimes you and others rely on this qualitative data from observations, interviews, oral histories. So I wondered if you could say a little bit more about this qualitative data and why it is so important when we consider the question of equity.
Sure. I very much think that the question of equity is not just about imagining what's possible, but also what's actually happening on the ground. And ethnography allows one to get to the, as I've been phrasing it, kind of the ordinary and everyday experiences of how that data is produced as well as consumed and disseminated. So without a kind of ethnographic method, one can't really understand the ways in which someone understands the benefits, the slippages, the absences that are found in kinds of what could be sort of understood generally as big data. And so qualitative research, particularly ethnographic research, allows a kind of what one could call a kind of snapshot of how that data is understood in the everyday kind of context, as opposed to, or at least in relationship to, how that data is networked across different kinds of institutions, as well as understood in its framework of a kind of future or past understanding of how those institutions use that data.
So you conveyed that some technologies have the potential to undermine racial stereotypes. Could you say a little more about what are these technologies and how they might be able to help us?
Sure. So this example of the water filtration kit, I think, is quite interesting in the sense that, you know, most people in Guyana since 2009, when these major climate adaptation projects have been happening around its dam and sea defense network, have recognized that the state has actually implemented these projects. Now, to what extent people would say that they've been to the design measures that everyone wants is, of course, up to debate. But no one can deny that these projects have actually happened. At the same time, people are still living with different kinds of risks related to flooding. And so it's people's very response to understanding that everyone is vulnerable, albeit in differential ways, that people then rely on these kinds of ordinary kinds of technologies, as I'm identifying here as a water filtration kit, to respond to the fact that they're vulnerable, but at the same time recognize their vulnerability is related to others. And so in that sense, I think this broader perspective of how literally individual experiences are related to collective experiences and how technologies allow people to see those connections is what attempts, or what gets people to think more broadly and to start to begin to deconstruct kinds of narratives about racial marginalization that frankly might not always be there in the specific cases of the crises that people are living with. But oftentimes people rely on those narratives as a kind of way to build kind of political mobilization as well as community in order to deal with the problem at hand. Now, of course, that kind of political capital is quite important, but again, there's a kind of nuance to the ways in which that political capital, I'm arguing, gets mobilized across the use of technologies in the everyday.
Okay, well, thank you, Sarah. I now am seeing that a number of questions have come in for our three guests. Let me start with a question for Ziad. It sounds as if a big part in discovering the bias of algorithms occurs by chance. Is there a structured approach, a more structured approach to discovering bias?
Yeah, I think that it's a it's a sad fact that even, our paper was mostly luck. We happened to have access to this data because of relationships we had with a particular hospital who had bought this algorithm. And in fact, we'd gotten the data for a completely different project and only understood that the real story was this bias story about 2 years into that project. So it was very ad hoc, and that actually should, I think, be a scary fact. So I think maybe there are two answers. On the one hand, I think that our work with regulators at the state and federal level has made me optimistic that there will be some kind of response that will be nuanced and actually quite appropriate for detecting and preventing this kind of bias that we discovered in these kinds of algorithms. And so that's good, and that's the way regulation kind of has to work, like one step at a time. But that approach, I think, will only really work after the kinds of biases are discovered and mapped out. And so I think for that, it's really important that people have access to data that they can use for research, not to kind of do more with the kinds of biases we know about, but to be figuring out the next kind, the kinds that we don't know about yet. And so I think that research is critically important. The access to data is really important. And I'd say that, exactly the kinds of things that Neela and Sarah were talking about, it is, that ethnographic approach that really is rooted in an awareness of the particular challenges that certain communities face is a really important part of that. So having people who both speak that language of, social science research, history, understanding structural inequalities with the people who can translate those insights into data, I think is really important. The big roadblock right now is getting those people access to data.
Thank you so much. A really insightful answer to that question, which of course welcomes our other two speakers to also provide some answers about how we might be able to structure our approaches for discovering this bias in algorithms and in the way we collect data. So Neela or Sarah, if you'd like to say anything about this.
Yeah, I'd like to, so there are a couple of things. One is, what is the algorithm even trying to measure? And Ziad touched on this, where most of the time it's extremely hard to know. Most of the time we're only looking at proxies. And so especially when it's something very vague that is not measurable, then measuring what bias even is becomes really hard. And we're doing some work around automated interview technology that takes in a video of you performing an interview and then does machine learning on it to get at things like your communication skills. And we're faced with the same problem where there is no measure of someone's communication skill that we could compare with and see whether the algorithm is doing the right thing or not. And so we have to fall back again on measuring bias or discrimination. And I think that something that's really important here is working with people who are in policy and law. So this particular project that I'm talking about is in collaboration with Professor Catherine Albiston at Berkeley's Law School. And we're sort of doing this work where we're moving the empirical work forward at the same time as we're moving the policy work forward, taking one step at a time to think about what empirical work can best justify and support the policy arguments that we're trying to make here. And so here again, like falling back on existing strides that have been made in employment law around discrimination or around ableism in employment law are things that we can really build on to get there. And yeah, like Ziad said, it's one step at a time. And then I'm also reminded of some things Sophia Noble said in a talk once, where she was saying, you can't put some ingredients together in your kitchen and sell it as an aspirin. You're not allowed to do that, but it's very strange that you can put together whatever algorithm you want and use it in such high stakes situations like health, employment, even whether or not someone goes to prison. So I think this is a place where we really have to be thinking about policy and working very closely with policymakers to think about how we might actually be able to mitigate these effects.
Right, and particularly again in the climate adaptation context, one of the ways I see researchers and policymakers trying to address this question of what is the algorithm that we should use to identify these biases, as well as what is the kind of data that goes into those algorithms, is literally around a kind of an old practice of long-range forecasting. And how is it that long-range forecasts themselves can be used towards different kinds of healthcare and public health policies in order to alleviate as well as help predict the ways in which different communities would be affected by health-related diseases as their ecologies and local environments change. And again, part of the work of the ethnographer then is to ask, what are the different kinds of connections, the different relations that are being made between law, say economic modeling, as well as meteorology, in order to understand the different ways in which health itself becomes a different kind of variable under different kinds of circumstances, as well as not just the different kinds of social demographics, but expectations people have about what an algorithm can or can't do for them, as well as different kinds of data sets.
So we only have a couple of minutes left for questions. One other question that has come up is, how is the pandemic playing out in less economically stable countries? There is an economic disparity among nations, and one of you maybe can give a 1-minute answer about how this is playing out in terms of the effects of COVID-19.
I'll just give one thought, which is to say that, you know, if you think that we have a bad data situation in terms of real intelligence about the epidemic in the US, those disparities are magnified by orders of magnitude in the developing world. We have so little idea of what's actually happening because all of our data are, again, coming out of healthcare systems where the same kind of challenges that Black patients face in the US are effectively faced by entire countries, and where the ability for people to get tested is so incredibly low that if we don't see any COVID cases in a country, does that mean things are going great? Or does that mean that we haven't even begun to test people and understand how big the epidemic is? So I think, again, that just highlights the need for not just relying on these biased systems to collect data for us, but to actually tackle those data collection challenges head on and go get the data, given the enormous economic value and the case for investing in data collection.
Yeah, I will say, as a specific,
unfortunately, I think it's time to wrap up, but I want to thank all three of you for your different approaches, Ziad Obermeyer, Neela Forrestal, and Sarah Vaughn. And I would also like to announce, and I would like to thank the audience for joining us here. And I would like to announce 2 upcoming Berkeley conversations, which follow closely on this. The first is on Friday, this Friday, April 24th, from 12 to 1 p.m. Pacific time. Straight Talk, a conversation about racism, health inequities, and COVID-19. So that will follow up on this one very, very nicely. And the second is next Monday, April 27th, 12 to 1 p.m. Pacific time. And that also follows very nicely, in particular, on what Sarah has been talking about, climate change and COVID-19. Can this crisis shift the paradigm of climate change? So again, I want to thank our 3 guests, and I want to thank everyone who joined us for this conversation from the Division for Computing, Data Science, and Society, and from the Berkeley Institute for Data Science, and of course from the Berkeley community. Thank you so much for joining us.